There's been a lot of hype on innovative approaches to creating AV access. In particular, there have been presentations in the past on 2 devices and their progress in creating fistula percutaneously. As one of the investigators for one of those devices, the ellipsis by AVF Medical, it's a privilege to be here to discuss percutaneous fistula, to present the long-term data from the Avenues FDA trial, as well as just to give my general thoughts on where I believe these devices will bring the greatest value. Here are my disclosures. So there really are only 2 devices in this space right now, both of which have the European CE mark, both have completed phase 3 trials and submitted them to the FDA. The first device is the ellipsis by AVF Medical. It's a 6 French single venous catheter system that creates a fistula by fusing the perforating vessel, perforating vein in the antecubital fossa to the proximal radial artery. Now here's a, see if we can get this video clip. Can you run the clip for me? So under ultrasound guidance, the perforating vein is cannulated with a micropuncture needle. The needle is advanced down until it crosses to the proximal radial artery. The needle is then taken out of the vein into the proximal artery, followed by a wire and a 6 French sheath. The ellipsis device is then advanced into the proximal radial artery, and then both the sheath and the device are withdrawn until it captures the arterial wall. So once this is accomplished, the device is closed, which then traps both the vein wall and the artery wall together, and then thermal heat is applied. And then it's just a matter of time, temperature, and pressure until the anastomosis is formed and the vessels fuse. So here the device is closed. We test it to make sure the walls are captured. Thermal heat's applied, and the fistula is created. Now in this case there was spasm that developed immediately, which was managed with balloon angioplasty, and that's one of the unique characteristics of this device is that the anastomosis is extremely durable and tolerates angioplasty with up to a 5mm balloon immediately after creation. This is all again done under ultrasound. And so you can see now that the spasm is resolved, the device is removed and just manual compression is held. So this is the characteristic looking anastomosis as seen by ultrasound. It's elliptical in shape, hence the name the ellipsis. And this is what it looks like under fluoroscopy. Proximal radial artery fused to the antecubital perforating vein. And there are a lot of benefits to this fistula that have been well described, as they tend to be lower flowing fistula. There's a lower risk of developing Steele syndrome, high output failure, as well as a mega fistula. And in addition, based on the anatomical location, it tends to leave multiple venous outflow options. Now the other device is the Everlink by TVA Medical. It is a dual catheter system. The original device required both a brachial artery and brachial vein catheter. And these catheters were then advanced into the ulnar system with fluoroscopic guidance, at which point magnets on the catheters were lined up, which would pull the vessels in close enough proximity that radiofrequency energy could then open a tissue channel. Now their phase 3 trial was conducted in Canada, New Zealand, and Australia. They had 60 patients that were enrolled. Their outcomes were very good. 87% of their patients achieved primary endpoint, and 64% were using 2 needles in their fistula by the end of the study. They did, however, describe 8% serious procedure-related complications, most of which were related to arterial complications. More recently, it's my understanding they're conducting a trial in Europe using a smaller caliber device. So here's a side-by-side comparison. You've got on the left tissue fusion with the ellipsis, and on the right, where the white arrow is, you can see the tissue channel between the vessels for the Everlink. So Avenu completed its phase 3 trial with long-term follow-up, and the results were reported in the JVR just recently, just in December. This was a multi-center trial. It was conducted at 5 sites. There were 8 investigators, 7 of which were interventional nephrologists, They enrolled 107 patients, both CKD as well as ESRD, and their primary endpoint was similar to prior studies that are similar to this, using as a surrogate marker brachiorartery flow greater than 500 cc's per minute and a target outflow vein greater than 4 millimeters, as well as looking at safety data in 90 days. So 95% of the patients had a fistula successfully created. There were 4 patients where there were technical challenges in crossing into the radial artery, and the procedure was aborted prior to the device being deployed. The average procedure time was just shy of 24 minutes. You can see there's a very large range there, a lot of which was just based on user experience over time. And I believe by the end of the trial, almost every investigator had created a fistula in 10 minutes or less. 86% of the patients achieved the primary endpoint. There were no serious device-related complications. Flow rates at 90 days as well as 1 year were very good. And 88% of the patients were using 2 needles for dialysis by the end of the 1 year follow-up at an average of approximately 100 days. And I'd like to pause there for 1 second and just compare that to the data reported by USRDS, which from surgical creation to cannulation was approximately 136 days. And just one other comment about the 100 days. So this included all patients, including patients who were CKD who converted to dialysis dependent beyond the 100-day point. If we look at the 12-month data based on Kaplan-Meier survival curves, the cumulative patency rate was 87%, the functional patency rate was 92%, and that compares very well to the surgical data on the right. In particular, the cumulative patency rate reported in the WOO trial, which was a meta-analysis of a surgically created proximal radial artery fistulas, is a good comparison since it's using the same anatomy. So as a nephrologist, practicing medicine today has become the alphabet soup of acronyms, quality measures, reporting, and how we're going to be paid or penalized in the future. And as we look towards alternative payment methods, including risk sharing, we're going to have to do a better job controlling upstream quality if we want to control downstream cost. And that's where I believe we have great opportunity to move the needle with these devices when they become FDA approved, especially for those of us who have freestanding access centers. So as an example, I put together this vascular timeline. So we recently converted our centers to ASCs and have a surgeon who comes over regularly to create a fistula. In doing this, we're now able to completely control the pre-surgical period, which in our community can easily take 2 months or more. So if we use these efficiencies and superimpose the data from Ellipsis as well as USRDS, you see that we have an opportunity to reduce the total vascular timeline by nearly 50%, which in a pre-established dialysis patient could equate to a decrease in total catheter contact time by 3 or more months. Now that has significant economic implications. We're part of an ESCO, and in our ESCO, it was recently determined that a catheter-dependent patient costs approximately $2,300 per month more than a patient with an AV access. So in summary, the data surrounding percutaneous fistula by both devices appears quite promising, and the outcomes appear to be as good as that surgical data. In addition, the fused anastomosis created by the Ellipsis appears quite durable, tolerating angioplasty immediately after fistula creation and allowing for earlier fistula maturation. On a personal note, and again, I only have experience using the Ellipsis, it's a pretty slick device. The procedure is really quite within our wheelhouse to be able to do. Patient satisfaction with the procedure was quite high, and although it won't solve all of our vascular challenges, it'll certainly be a great asset to add to our arsenal.